diseases could be similar to each other, and most of the treatment, it could be the same. So, in fact, it is a highly specialized nephrologic subject. But as I have agreed with you that you are still beginners, and I have to give you only the guidelines and to know to know a little bit, few data about this very tough subject, which is called the glomerulonephritis. You know, glomerulo is related to glomerulus, which is one component of the nephron, and nephritis, it means inflammation of the kidney. So let's start saying about glomerulopathies versus glomerulonephritis. In books, you will find the two terms, glomerulopathies and glomerulonephritis. The glomerular disease, it includes glomerulonephritis, i.e., glomerulonephritis means inflammation of the glomeruli. Glomeruli, it is the group of glomerulus. So glomerulonephritis, it is inflammation of the glomeruli, and glomerulopathies when there is no evidence of inflammation. So in a glomerulonephritis, we will find inflammation, but in pathies, there is no evidence of inflammation. And to simplify it, glomerulonephritis is considered a subset of glomerulopathies. So the big group is glomerulopathies, and it includes what's called glomerulonephritis. If you remember yesterday, when we talked about chronic kidney disease, the third cause of the chronic kidney disease was the chronic glomerulonephritis. But the first two causes, again, those are outside the kidney itself. First, diabetes, and second, hypertension. Third, glomerulonephritis. So from the beginning, glomerulonephritis could end with end-stage kidney disease. The classification of glomerulopathies. First group, it is nephrotic syndrome. Second, it's acute glomerulonephritis. Between brackets, acute nephritic syndrome. You will find later that we have two entities, nephrotic syndrome and nephritic syndrome. And there are big differences between each of them. Third group, it is called rapidly progressive glomerulonephritis. From its name, rapidly progressive means it is badly going to the bad situations. It is rapidly progressive. And fourth, we have asymptomatic urinary abnormalities. Some patients come only complaining of hematuria or proteinuria. Some are complaining of both hematuria in addition to proteinuria. So in front of this complaint, we have to remember glomerulonephritis or glomerulopathies. Again, glomerular disease is classified according, is it primary or secondary? When it is a primary, this means that glomerular disease is confined to the kidney itself. And it arises, this situation arises from the intrarenal tissue. It is kidney related only. But when we say secondary all the times means that it is caused by another etiology. Secondary glomerular disease, mostly it is due to a systematic disease. There are many systematic diseases, especially the rheumatology diseases. As an example, and usually it is a common example, lupus, SLE. What are the possible clinical manifestations? As I told, some may present with proteinuria, which is mostly asymptomatic. Asymptomatic proteinuria. It doesn't mean that some patients have symptomatic proteinuria. Symptomatic proteinuria, it is meant here that proteinuria is accompanied by other manifestations. Other people present with hematuria, which is also asymptomatic. It could be, in another way, it is called painless hematuria, because some hematurias are painful and the etiology is completely different. As an example, hematuria due to kidney stone, mostly it is painful hematuria. But here the hematuria is asymptomatic. And you know, hematuria has two classifications, whether macroscopic hematuria or microscopic hematuria. Some people present with hypertension. You remember, hypertension could be a cause and could be a result of most of the kidney diseases. Some present with what's called nephrotic syndrome. And I think inshallah, in near future, we will say about the two entities, nephrotic and nephritic syndrome. But maybe it is delayed to the second semester. I hope so. Some present with acute kidney injury. Many patients presenting with acute kidney injury, which is not corrected and which may need dialysis, one of the renal workup in this case to go and to do kidney biopsy. And at the end of the day, we will be faced by one of the glomerulopathies causing that acute kidney injury. Again, rapidly progressive renal failure. It could be a presentation. It could be a presenting manifestation of this disorder or of this syndrome. Again, it is a clinical pathological syndrome. Some people may present with end-stage kidney failure. They are presenting, and the first thing to do for them is to dialyze them to save their lives. Then we go back retrogradely, biopsying their kidneys, and we will find they have one of the glomerulopathies, which could be corrected and treatable. Glomerulonephritis, the presence of a glomerular disease as opposed to tubulo-interstitial. You remember the components of the nephron or of the kidney are glomerulus, tubules, interstitium, and vascular compartments. So at least we are speaking about the types or the components: glomeruli, tubules, and it has many types, interstitium, and vascular component. So presence of glomerular disease as opposed to tubulo-interstitial or vascular disease. Look, tubulo-interstitial, it means both the tubules and the interstitium, both may present with one pathology. Or vascular disease is suspected from the history of the patient. So again, taking a thorough history is mandatory because it gives you a good clue or a good clinical impression about your patient. When we are saying about hematuria, the most important thing Sometimes when we have a urine analysis and there is hematuria, we ask for the morphic or the morphia of those red blood cells, the shape of the red blood cells. And mostly in this entity, we have what's called dysmorphic red cells. Dysmorphic, this means multiple shapes of the red cells, not monomorphic. And when we have dysmorphic, it is very important point. When we have dysmorphic red cells, usually it relates to nephrology, glomeruli. But when we have monomorphic, usually it is a urologic entity, and we refer the patient to the urologist. Sometimes we have, again, red cell casts, which is a rigid pathologic sign in the urine analysis, and it denotes to the glomeruli itself. We have lipiduria, I mean urination of lipids. Glomerular permeability must be increased to allow the filtration of large lipoproteins. So lipiduria means high permeability of glomeruli. And lipiduria nowadays is added to the definition of the nephrotic syndrome. We will discuss it later in the future. Proteinuria. We have two types of proteinuria, as I have told you before. We have what's called the non-nephrotic range proteinuria, which is less than 3.5 grams daily, or the nephrotic range proteinuria, which is more than 3.5 grams daily. And proteinuria, mostly in nephrotic, it is of nephrotic range, i.e. more than 3.5 grams daily. This slide is a little bit sophisticated, and I think I have to skip it because it is not correlating with your situation. It speaks about immunity, antigen and antibodies, because you have to know that most, if not all, of glomerular diseases are related to autoimmunity. Again, it is the pathophysiology. Antigen, let's say as an example, group A, beta hemolytic streptococci. It leads to antigen-antibody product. It leads to deposition of antigen-antibody complex in the glomerulus. It is the pathology etiology. So we have antigen-antibody complex in the glomerulus itself. This leads to increased production of epithelial cells, which are lining the glomerulus. We go to leukocytes infiltrate from the glomerulus, and thickening of the glomerular filtration membrane. We have a filtration membrane, it becomes thickened. That thickened membrane becomes scarred, and there is loss of glomerular filtration membrane because it is thickened and becomes non-functional. At the end, we end up with decreased GFR, decreased glomerular filtration rate. I mean, decline of the function of the kidney. So it is the pathophysiologic etiology of that glomerulonephritis. Look, mostly it relates to immunity, antigen, antibody, and complex. Again, pathology, we will concentrate on immune complex disease. So we have complements, leukocytes. We have what's called complement leukocyte mediated mechanism. We have two mechanisms. I think no need to go deeply through them, but to know as guidelines, we have in the pathology two mechanisms, because let's say all glomerulopathies, the key point of diagnosis is the kidney biopsy, and the master of diagnosis is the pathologist himself, not the nephrologist. So the pathology mechanism, we have two categories. First cause, complement leukocyte mediated mechanism, and second, complement dependent. And I think the details are no need to dig into it. Again, let's go to the clinical. Glomerular disease. It is named according to 3 points, whether etiology, whether microscopic findings, and the third category is a clinical syndrome. As I told you, it is a syndrome of multiple clinical pathologic diseases or entities. Glomerular disease is most common clinical presentations in the, and mostly it is presented by acute nephritic syndrome, which we will speak it in the future, and nephrotic syndrome, two entities with two speech on each other and two modalities of treatment. The glomerular disease is the most common in it, as I told you, the most common cause in the glomerular disease, it is autoimmune disease. Antigen-antibody complex deposits on the glomerulus. So it's an explanation on what's going by autoimmunity. Let's speak about some subgroups of this major category. Let's take as an example, it was called post-streptococcal glomerulonephritis. Nowadays, it is called post-infectious glomerulonephritis. Let's say it as an example. Post-streptococcal, this means there was an infection with the streptococci. I told you most of the etiologies are due to inflammation and autoimmunity. But here, look, the beginning was infection with streptococci, and the consequence, it was related to that. So post-streptococcal glomerulonephritis, it is autoimmune injury. Now it is post-streptococcal. The infection is already cured. So the infection is finished, but it gives us some source of autoimmunity. So that post-strep glomerulonephritis, it is autoimmune injury initiated. The initiator was what's called beta hemolytic streptococcus. Beta hemolytic streptococcus, it is one type of streptococci. This beta hemolytic, it is specific to cause this situation. So, post-streptococcal glomerulonephritis, also known as AKA, also known as acute proliferative glomerulonephritis. Proliferative means it is growing up. It may present as acute nephritic syndrome. Look how those many entities are going inside each other. So it is a little bit confusing subject. And I told you from the beginning, it is one of the most difficult chapters in nephrology. Needs the help of the pathologist. So it may present as acute nephritic syndrome. In acute nephritic syndrome, we have hematuria, we have hypertension, We have increased kidney function, I mean declined kidney function by increase of urea and creatinine. We have low urine output, diminishing urine quantity, and as a consequence, we have edema, accumulation of fluids. In this entity, antibodies are produced by streptococci, throat infection. Most of patients, if you take a thorough history, they have 2 or 3 weeks a history of a strep throat infection, tonsillitis or pharyngitis or whatever you want. That strep antibodies are deposited in the glomerulus. Most fully, they recover those patients. Most of them, they recover. I mean, 90% of this entity is curable. But remember, there is about 10%, they evolve into what's called rapidly progressive glomerulonephritis, which holds a poor prognosis. So not all post-strep patients are in a safe situation, only 90%, but 10 may or go to chronicity and develop what's called rapidly progressive GN. Rapidly progressive GN, it means it's of unknown, in fact, it's of unknown causes if it's primary, or secondary if it's due, as I have just said. It could be secondary if it is due to post-streptococcal glomerulonephritis. So this entity, rapidly progressive GN, mostly it is of unknown causes or secondary to post-streptococci infection. If it is primary, it is autoimmune. Also, it is known as a new entity. In this subject, each entity has other names, 1 name, 2 names, and 3 names. This entity is also known as crescentic glomerulonephritis. And you know what's the meaning of a crescent. Crescent باللغة العربية معناها الهلال. It is a crescentic glomerulonephritis. And look at the pathologic picture. The arrow goes to the crescent of proliferating epithelial cells. It is not for you, but just to make a demo for you. Some patients present as acute nephritis, as acute nephritic syndrome. Acute nephritic syndrome means there is all the time hematuria and red blood cell casts. Others may present with renal failure from the beginning. So from the name rapidly progressive, it holds a very poor prognosis. Again, it is caused by the etiology, deposition of an antibody complexes. So it is autoimmune. The beginning was infection with the streptococci, but the consequence, it is autoimmune. All but a few patients progress to renal failure. Look, all will progress to renal failure, but a few will be cured. So it is again a very risky, very dangerous disease, and it holds a poor prognosis. Let's go to another example of this big group of glomerulonephritis. We have what's called membranous glomerulonephritis. And if you look at the pathologic picture as a guideline, membranous means there is a thickening of the membrane, of the basement membrane. So that thickened basement membrane gives us the name membranous. Membranous related to membrane. It's autoimmune disorder. Most common cause of It is the most common cause of nephrotic syndrome in adults, especially in our countries, in our Arabian countries, or in our region. The most common cause of nephrotic syndrome, if we have many patients with nephrotic and we do biopsies for all, most of them will present with a pathologic diagnosis of membranous glomerulonephritis. But in the Western sphere, nowadays, especially if the patient is a Black American, the pathologic diagnosis, mostly it is what is called FSGS, glomerulosclerosis. So it deviates by the geographic changes. But here in our countries, membranous is still number one in adults. About 10% of those patients proceed to kidney failure within 10 years. So it is a risky entity. 10% of them will go to dialysis or to transplant within 10 years. But 25% will recover completely and irreversibly. Those people are lucky because they have been recovered. The other 10 will go to end stage, 25 will recover completely, but the most of the remainders will progress slowly, slowly. And they are having proteinuria, hypertension, loss of renal function. So they are progressing but slowly to end-stage kidney disease. So the most lucky group in this entity is the 25% who will recover completely. Other people will go rapidly to end-stage kidney failure or slowly, but they will reach it at the end. Let's speak about what's called chronic glomerulonephritis, which we have said yesterday that it is the third cause in etiology of chronic kidney disease. Incidental discovery of occult proteinuria or hypertension. Sometimes your patient is asymptomatic, but you, as a smart doctor and by your investigations, you find, by the way, incidental, you find occult proteinuria or hypertension. You find your patient hypertensive and you start to look for the causes of that hypertension. Those patients or this entity usually presents as a chronic renal failure. Remember yesterday, we considered this entity the third cause of end-stage kidney disease. Or it is a cause of occult proteinuria, which is a pathologic condition. A glomerulus has scar tissue. This means glomerulus was injured one day and it is scarring. That scar means chronicity. And most of them will go to what is called kidney replacement therapy, as I told yesterday, whether dialysis or transplants. And the transplant, again, it is the golden solution. Secondary glomerulonephritis, when there is a cause, it is related to a cause. But the primary, it is of unknown cause. It is idiopathic. Secondary, the most common cause of glomerulonephritis as a secondary cause, it is diabetes. Diabetes is the most common cause. Remember, diabetes is the commonest leading cause of end-stage of chronic kidney disease. And remember, glomerulonephritis, it is the third cause of chronic kidney disease. But remember that DM itself, which is the first cause, it also commonly caused the third cause of chronic kidney disease. So again, DM is a very aggressive and a very difficult disease to be treated. We don't treat the disease as a disease. We are afraid and we treat its complications. Glycoproteins in this situation deposit in the basement membrane. And the second of the secondary causes, it could be vascular disease of the kidney itself, like atherosclerosis, whether generalized or localized, hypertension, and vasculitis. Again, vasculitis, it could be an autoimmune disorder. Let us look at the characteristics of the common glomerular disease at presentation. Diseases at presentation. Let's take 3 conditions, or more than 3 conditions. Let's take 5 conditions and see what's the manifestation, the most common manifestations of each. Let's speak about heavy proteinuria. When we say heavy proteinuria, this means that the patient produces proteinuria more than 8 grams per day. Under heavy proteinuria, we will find examples of GNs like minimal change disease, which is a type of glomerulonephritis. We will find focal sclerosis, number 1 in the Blackish American Africans, focal sclerosis. We will find membranous, number 1 in our area. We will find diabetes itself and amyloidosis. So those amyloidosis, diabetes, membranous glomerulopathy, focal sclerosis, and changes, mostly they present with heavy proteinuria. But others may present with proteinuria, which is not heavy, mixed with hematuria. Let's give you some examples. Patients with lupus nephritis. You know, patients with SLE, the first organ to be affected by the SLE is the kidney itself. And when the kidney is involved by the SLE, we are in front of the entity lupus nephritis. In lupus nephritis, we have mixed proteinuria and hematuria. Other examples, membranoproliferative GN, sometimes in endocarditis, which is a cardiac condition, we may have proteinuria mixed with hematuria. Again, you know about henochal line purpura. It is a hematologic disease. And in this henochal line purpura, you will find proteinuria and hematuria. Other entities present with predominant hematuria only, without proteinuria or without a significant proteinuria. As I told you, there's nephrotic range and non-nephrotic range proteinuria. But in these situations, hematuria is the predominant, is the master of the disease. Those examples are acute post-streptococci GN, crescentic GN, or what is called rapidly progressive GN, which is one of the bad entities in this bad group of pathologies. And you know about HUS, hemolytic uremic syndrome. Mostly they present with hematuria because look, there is an evidence of hemolysis. Hemolysis with declining of the kidney functions. It is hemolytic uremic syndrome. Acute glomerulonephritis again. By definition, it's acute glomerulonephritis. It is the inflammation of the glomeruli, which causes the kidney to have malfunction. So it's called acute, sometimes it's called acute nephritis, not a glomerulonephritis. Because nephritis, it is the whole of the kidney, not part, glomeruli. A glomerulonephritis and post-streptococcal glomerulonephritis could be same entities. You cannot differentiate unless you take a good thorough history, and the key point of differentiation, it could be, as I told you from the beginning, the pathologic diagnosis. The difficulty of this subject because it needs a pathologic or a tissue diagnosis between brackets kidney biopsy. You cannot diagnose it without a kidney biopsy, all those conditions. By definition, acute GN, it predominantly affects children from the ages from 2 to 12. It is predominantly, but it is not an absolute rule. It may affect adults also. So in medicine, there is no absolute rule. Its incubation period mostly ranges between 2 to 3 weeks. On average, of course. I told you nowadays they have changed the name from post-streptococci or streptococcal in GN to post-infectious, because they have found that there are other pathogens can cause this entity by autoimmune diseases as a consequence. Let's look at the infectious causes. Mostly it is streptococci or non-streptococci post-infectious GNs. It could be bacterial, not only the streptococci, it could be viral cause. And lastly, it could be parasitic cause. In non-infectious etiology, it presents with multi-systemic diseases. So it is involving multi-systems, or it becomes as a primary glomerular disease. Again, pathogenesis, which is a little bit difficult. There is M protein that streptococci has what's called M protein. It was felt to be responsible for post-streptococci GN. M protein, one component of the pathogen. It was believed previously, but recently, nephritis associated with the streptococci, there is what is called cationic protease, and its zymogen precursor, in a brief, NAPR. It is just an idea to you. It is not necessary for you. This NAPR, it has been identified as glyceraldehyde 3-phosphate dehydrogenase that functions as a plasmin or plasminogen receptor. These sophisticated data, and I don't advise you to know too much about it. We have antibodies levels to an APR. They are elevated in post-strep infections, especially group A, C, and G of the streptococci. Those are associated with GN, but are not elevated in streptococcal infections without GN, whereas anti-streptolysin O titer are elevated in both circumstances. One of the parameters we were asking, anti-streptolysin O titer, and it must be normally must be less than 200 TODs unit. The name of the unit is TOD, T-O-D-D, TODs unit. In pediatrics, you will be taught something about this. Again, the pathology, it is something complicated. We have diffuse proliferative GN. There is a proliferation growing up of cells within the glomeruli. That is accompanied by leukocyte filtrate because it's inflammation. There is typical features of immune complex disease. Remember, the key entity, it is immune complex deposition. We may have hypocomplementemia. You know the complements from C1 to C9. Mostly, we will find those complements are decreased, especially C3 and C4, especially in lupus nephritis. We may find the granular deposits of IgG and complement on glomerular basement membrane. There is implicated antigens seem to be endostreptocin and nephritis. Remember, implicated, not approved, or plasmin therm. Here is better to know, and it is better to be clinicians rather than pathologists. General symptoms of those situations or of that situation, patients may present with fever, with headache, malaise, anorexia, nausea and vomiting, high blood pressure. They may be pallor due to edema and or anemia. They are edematous, so they have anemia, which could be delusional anemia, as I have told yesterday, because of increased interstitial fluids. They may be presented with confusion, lethargy, loss of muscle tissue, and enlargement of the liver, hepatomegaly. Sometimes you find that the liver enzymes are elevated because the liver is one of the important organs of the body, and the kidney is the secretory, and the liver is affected by any kidney disease and vice versa. There's an entity called hepatorenal syndrome. If you examine your patient, what signs you will find and what are his symptoms? Hematuria, he will tell you that he has or he passes a dark brown urine, remember, dark brown, or smoky urine, urine as if there is a smoke in it, or frothy urine. Oliguria, again, as defined, it is less than 500 nowadays, not 400 ml per day. and anuria is less than 100 ml per day. If your patient is edematous, that edema starts in the eyelids, puffiness of the face, or the eyelids, puffy edema, or puffy face. We are saying facial puffiness. Then that edema may go to the lower or upper limbs. Then it becomes generalized, what's called anasarca. It may be migratory edema. One day this part is edematous, that day that part is edematous. You remember while we were making lectures face-to-face, I have told you that at least we have 6 types of edema. We have hypertension. That hypertension is usually mild to moderate, but not severe. Not severe, I mean, rarely it causes organ damage. In clinical syndromes, we have urinary points such as hematuria or proteinuria. In nephritic syndrome, we have edema, hypertension, gross hematuria, and proteinuria. Look, in nephritic, the predominant thing is gross hematuria. But in nephrotic, proteinuria is the predominant. Both nephritic or nephrotic have edemas, proteinurias, hematurias, but in nephritic, hematuria is the dominant, and nephrotic proteinuria is the dominant. All of them will develop what's called hypercholesterolemia or hyperlipidemia, the best name nowadays, because not only the cholesterol will go up, all of the lipids will go up, and they will develop hyperlipidemia or what's called dyslipidemia. And those manifestations could be mixed with each other. Look here in the picture. It's a sample of urine under centrifugation, and look at the color. Abrupt onset of glomerular disease. We will find red blood cell casts or dysmorphic red blood cells. So when we have dysmorphic blood cells, it relates to glomerular disease. When we have casts of red blood cells, it also relates to glomeruli. In non-nephrotic range proteinuria, which is less than up to 3.5 in 24 hours, we have this situation. Again, edema, mostly periorbital edema, especially at morning. The patient says, when I am awakened from sleep, I have a puffy eyelids. Or it could be sacral edema at the lower part of the back. Hypertension, it is a finding. And we will have oliguria or uremia. So we are in front of renal dysfunction. The kidney is non-well functioning. If we go to investigations, we will find the following. The parameters of kidney dysfunctions, we will find that urea and creatinine are increased or going up. If you do urinalysis, midstream urinalysis, you will find under the microscope this shape, which is called red cell casts. It is the shape of the red cell cast. And you may find in the urinalysis proteinuria. But when you see red cell cast, it is something couldn't be forgotten, and it is something meaningful. In complications, we may find hypertensive encephalopathy, heart failure, and acute pulmonary edema. Those may occur in the severe cases of the GNs. But in acute renal necrosis, which is due to injury of capillary or capillary thrombosis, we will find again many manifestations due to vascular thrombosis. And we are in front of acute renal necrosis, which is also a bad situation. To prevent the condition, prevention as much as we can. We have to do proper hygiene of the body, especially the urinary system, to prevent any infection or any, let's say, non-hygienic condition. Let's go to prompt medical assessment for necessary antibiotic therapy. Should be sought when infection is suspected. As an example, if we suspect urinary tract infection, we have to properly confirm its diagnosis, and we have to properly treat that infection to let the patient be cured. And in this case, we are, let us say, we are saving his kidney, because you know that recurrent UTIs, which were not treated well or not diagnosed well, may have bad impact on the kidney, and it could be a cause of a chronic glomerulonephritis. Sometimes we have prophylactic immunizations. Let's say what's going nowadays about COVID-19. Nowadays we have vaccinations for it. And if you know that at least 20% of patients who develop COVID-19 may present with acute renal shutdown, and they may need dialysis. But if they were immunized, the percentage will be less and less than this. So immunization programs are important in the prevention of all diseases, not only the kidney disease. In a treatment, we will go through antimicrobial therapy. If we have an infective cause, we give antibiotics. Previously, penicillin was safe to be given. It controls symptoms and the prevent of infection. But nowadays, we have many new generations of good antibiotics, which are safe to the kidneys and very potent in their efficacy. Antimicrobial therapy does not appear to prevent the development of GN, except if given within the first 36 hours of that situation. So this gives us a hidden message that the earliest diagnosis, the best the outcome. What's about loop diuretic therapy, like furosemide, Lasix, or butenamide? Loop of Henle, as you know, loop diuretics may be required in patients who are edematous, because those diuretics are anti-edematous factors and who are hypertensive at the same time. Why? In order to remove excess fluid from his body and to induce hypovolemia, which may correct his hypertension. Again, diuretics may relieve edema and control volume. thereby helping to control volume-related elevated hypertension. This is the same idea. What's about vasodilator drugs like nitroprusside, nifedipine, hydralazine, diazoxide? Those may be used if severe hypertension or encephalopathy is present. So you have to remember that we have urgent hypertension and emergent, and each entity must be treated in a different way, but both are risky and must be taken seriously. What's about diet? Again, sodium and fluid restriction is important because we are going to reduce edema. Protein restriction is important also for isotemic patients, isotemia, because I told you yesterday that protein excess is considered an enemy of the kidney. So we reduce the intake of daily protein amounts. What's about activity? It's recommended that bed rest until signs of glomerular inflammation must be done and circulatory congestion subsides. So activity, it is not advisable in this situation. The patient must be hospitalized and take some evidence of bed rest. How to manage post-strep GN? It has, that entity has a good prognosis, as I told, 90% will be recovered, but 10 will be chronized. We have to use supportive measures until spontaneous recovery, so they may recover spontaneously. If they are hypertensive, we have to control it. We have to be assured of fluid balance. What's the tip and the top? What's the total input and which is tip, and the total output, which is top? So we have to make a balance between tip and top. When we have oliguria with fluid overload, of course, we have to use the diuretics. When we have GN complicating lupus or systemic vasculitis or vasculitis, which is a big group of vasculitis, we have to use what's called immunosuppressive agents with cortisone, steroids, prednisolone. Sometimes we use what's called cyclophosphamide or azathioprine or MMF. Those agents are immunosuppressive agents, and they are commonly used according to the pathologic diagnosis. But in general, steroids could be the main common factor for each. In a chronic GN, this condition is characterized by irreversible. This means we are going to end-stage kidney disease, and the progressive, irreversible and the progressive, glomerular and tubular interstitial fibrosis. In other words, the kidney is failing. This failure is ultimately leading to a reduction in the GFR, glomerular filtration rate. And when GFR, as I told yesterday, declines, we will go deeply in the stages, let's say from stage 3 to stage 4. And there will be a retention of uremic toxins, as told yesterday. If the disease progression is not halted with therapy, not stopped or not delayed by therapy, the result is chronic kidney disease, CKD, which has the stage 5, which is end-stage kidney disease. And we will find a cardiovascular disease because as we have hepatorenal syndrome, we have cardiorenal syndrome. I told you kidney is affecting and being affected by others. So the diagnosis of chronic kidney disease can be made without knowledge of the specific cause. I told you yesterday that 3% of the etiologies of end-stage kidney disease are not yet known. It's called missing causes. And chronic GN, it could be that missing cause. Etiology, again, nearly all forms of acute GN have a tendency to progress to chronic GN. Like any disease, when it is acute, not treated, it may become chronized. This progression from acute to chronic is variable. Variable means changeable. Sometimes it could be rapid progression and sometimes it may be slow progression. Whereas complete recovery of renal function is the rule for patients with post-strip again. Post-strip, it is one of the conditions which hold a good prognosis in 90%, but in 10% they may chronize. Several other glomerulonephritis, such as immunoglobulin IgA nephropathy, as an example, often have a relatively benign course. Sometimes we have a pathologic entity called IgA nephropathy. It's often benign course. Look, often, but not always. And many do not progress to end-stage kidney disease. So, in brief, any patient with glomerulonephritis, whether he will reach end-stage kidney disease or not, it depends on the following factors. The early diagnosis, the time when the patient comes to his physician, the good investigations, and the good treatment. Those factors may reduce the rapid progression to the end-stage kidney failure. Pathogenesis, it is reduction in nephron mass, as I told yesterday, from the initial injury, which reduces the GFR. This rejection of the mass of the nephrons, it leads to hypertrophy as compensatory mechanism and hyperfiltration of the remaining nephrons. I told you when a nephron dies, it is irreversible death. So the remaining, its brother nephron will compensate and hyperfiltrate. And after a time, it is the initiation of intraglomerular hypertension, which is a bad physiologic situation. These changes occur in order to increase the GFR. The GFR is threatened of declining. Those neighboring nephrons are trying to prevent GFR from decline. They are trying to increase it. But at the end, they're minimizing the functional consequences of nephron loss. When there is more nephron loss, there is more kidney decline function, renal dysfunction. The changes, however, are ultimately detrimental because they lead to what is called glomerulosclerosis, when the glomeruli or the glomerulus becomes sclerosed. And when it is become sclerosed, it means it is non-functional glomerulus. And there is more and more further nephron loss. In histology, in the early stages, the glomeruli may still show some evidence of the primary disease, But in advanced stages, the glomeruli are hyalinized and obsolescent, i.e., in the advanced stages, the glomeruli are looking exhausted, looking diseased, looking non-compensatory, and they are really dying. But the tubules are disrupted and atrophic. Again, it is a declining science, disrupted and atrophic tubules, and marked interstitial fibrosis. Look, there is glomerulosclerosis and there is interstitial fibrosis. Both are two faces of one coin. The address of both is malfunctioning or non-functioning. And the arterial and arteriolar sclerosis also occurs. In brief, the kidney is failing by all of its components. It's an example of what's called minimal change disease. You will see this disease mainly in children while you go to pediatrics. The title of the pathology here, it is the fusion of podocytes on the electron microscopy. Just to remember that podocytes are separated. When they are fused, we are in front of minimal change disease. Especially, this disease comes especially in children, and it holds a good prognosis if it treated well, and it is responsive to steroids. Again, number one in the Blackish American, African Americans, it is focal segmental glomerulosclerosis, which is a very bad entity, and it is still controversial issue, and all nephrologists of the world are not yet with an agreement on it, how to treat, when to treat, what's about the prognosis. So it is still a controversial issue, but it is, I can say it is one of the poorest entities in this big group of GNs. We have another entity, mesangiocapillary GN, large glomeruli with mesangial proliferation and double basement membrane. Two histological types. It has two histological types. It is not important for you. We have subendothelial deposits, which is type 1, and intramembranous deposits, which is type 2. Again, it is pathologic data, and now you are not yet being pathologists. In our countries, as I have told you, membranous is the most common, and it is the pathologic findings, which I don't want to upset you with the details on the electron microscope. We have mesangial proliferative GN. So I told you from the beginning, we have many names, many entities, and many names for every entity. And you will, at the end, you will be confused of this very hard subject. And if there is no kidney biopsy, we know nothing about this subject. In that mesangial proliferative, we have hypercellularity, mesangial proliferation, inflammatory cell infiltrate, positive immunofluorescence for Ig, G, and C3. And by electron microscope, we have subepithelial deposits. Remember, no kidney biopsy is considered right unless it is read by three modalities. First, light microscopy. Second, IF immunofluorescence. And third, which is the most diagnostic, which is what is called electron microscopy, EM. And the EM facility is not available anywhere. It is available only in the teaching hospitals or the high-ranked medical centers. So, because it is very expensive machine. And we need what is called a renal pathologist, not a general pathologist. Even in pathology, we have subspecialties. We need a renal pathologist to read our biopsy specimen. Again, symptoms are almost the same in each entity. Uremia, related findings, edema, hypertension. The JVP is distended. It reflects volume overload when JVP is elevated. Pulmonary rales or crackles if there is pulmonary edema. Pericardial friction rub if there is pericarditis, which is dry pericarditis, then goes to pericardial effusion. It could be tenderness in the epigastric region because of hepatomegaly, or blood in the stool, possible indicators for uremic gastritis. Gastritis which is induced by urea, or enteropathy. We have an entity called uremic enteropathy. And if you go to dialysis patients, most of them are suffering from diarrhea every now and then, or constipation. It is enteropathy. Sometimes we have decreased sensation and asterixis, which are indicators for advanced uremia. You know what's meant by asterixis? It is the flapping tremor. It is a sign of liver cirrhosis, hepatic coma, or uremic status. In a clinic, sometimes we have clinical variants. Medicine is not typical. No, all presentations are typical. Sometimes you have unusual presentation. So it's called variants. Like latent, the changes in the urine are latent. Sometimes hypertensive people. Sometimes you find normotensive people. So it is not an absolute rule. Hematuria also. Nephrotic range proteinuria or edema. Hypoproteinemia, hypercholesterolemia, or mixed picture. But almost the presentations of these entities are unusual. So it depends on the smartness on the attending physician, i.e. nephrologist. Lab studies, the renal workup, which is urine analysis, urine protein excretion, which is called spat urine, or protein to creatinine ratio. In nephrology, we use the term urinary PCR, protein creatinine ratio. If the PCR is 3, this means the patient passes 3 grams of protein daily. We go to serum chemistry, like creatinine, BUN. Those are elevated. Sometimes hyperkalemia because impaired excretion of potassium. Free water and acid results in hyperkalemia also. Hyponatremia, low serum bicarbonate levels, they are acidotic respectively. About vitamin D, it's impaired mostly because the production results, the impaired vitamin D3 production results in hypocalcemia and hyperphosphatemia and high levels of parathyroid hormone, PTH, as I told yesterday, what's called hyperparathyroidism. We have low serum levels of albumin, which may present if uremia interferes with nutrition or if the patient is nephrotic. Remember, nephrotic syndrome One of the manifestations is massive proteinuria and hypoalbuminemia. Sometimes we go to ultrasonogram images, renal imaging. We obtain a renal ultrasound to determine renal size, I told you yesterday, to assess the presence of both kidneys. Sometimes your patient is found to be with a single kidney, and he or she doesn't know about that. It is congenital cause. He was created or he was born with a single kidney. And we do ultrasonogram to exclude structural lesions that may be responsible for his isotonic status and to rule any obstructive lesion. Small kidneys often indicate an irreversible process. This point is very important. Many times we are asked, when we want to dialyze a patient, we are asked from the patient and from his family, doctor, will this patient be on dialysis forever or just for a temporary period? The key answer of this question is the kidney size, which is discovered from ultrasound or CT. If both kidneys are shrunken, it is a sign of a chronic kidney disease, and mostly 99.9%, it is a reversible process, and we will go to kidney replacement therapy, whether dialysis or transplant. Again, treatments, we have told about them, most of the groups, to treat edema, to treat hypertension. Renal osteodystrophy, we have discussed yesterday. We have to replace vitamin D, and we have to give phosphate binders to reduce the level of hyperphosphatemia. We have to seek and treat non-uremic cases of anemia by, such as patients, most of them are iron deficient. So we will give them, we have to replenish their iron stores before instituting therapy with erythropoietin. We have to give them, i.e., iron status in the body is important before being given what is called ESA. ESA, I have told you yesterday, it is erythropoietin, which is synthetic. ESA, erythropoietin stimulating agents. But those ESA will not work if the background of iron stores are poor. We have to discuss the options for kidney replacement therapy, which is dialysis, or dialysis means hemo or peritoneal, or renal transplant, which is the best. If there is hyperlipidemia, we have to treat it. Previously, they were saying no need to treat hyperlipidemia because it is a consequence of the nephrotic syndrome. But nowadays, it must be treated for the sake of the heart because it is still a risk factor. Expose patients to educational programs for early rehabilitation about dialysis and or transplantation. We have to educate our patient about his disease and about the future of his disease. Minimal change disease, it is a disease of children. You will see it when you do pediatrics, and it is a disease which is responsive to steroids, and its prognosis is very good. Only 1% of those patients will progress to end-stage kidney disease. Focal segmental, I have told you, it is the disease of a blackish African American, and its prognosis 30 to 50% will progress to end-stage kidney disease. and it is still a controversial issue between the nephrologists themselves. Mesangiocapillary treatment is not of a proven benefit right now, and the prognosis 50% will go to end stage. Membranous, it is the disease of our areas. Prognosis, if untreated, if untreated, 15 will develop complete remission without a treatment. 9% will go to end stage at 2 to 5 years, but 41% will go to end stage after 15 years. So membranous, it must be, we have to look at seriously, because some lucky people are cured spontaneously without treatment, but others need treatment to prevent or to slow their development of end-stage kidney disease. Mesangial, as I told, we have to use antibiotics if there's some sort of infection, diuretics, antihypertensive agents if he is hypertensive. Dialysis is rarely required in mesangial proliferative. It holds a good prognosis. Rapidly progressive, from its name, it's a horrible disease because it is rapidly progressive. It is a disease of the kidney that results in a rapid decrease in the GFR, and at least 50%. It is a horrible 50% at least over a short period. From a few days to 3 months will end up with end-stage kidney disease if not treated in the proper way. So rapidly progressive, it is a horrible progressive disease. Etiology, we have what's called ANCA and ANCA activated, ANCA anti-neutrophilic cytoplasmic antigen. Again, we will go through autoimmune process, and sometimes those patients may present with the flu-like symptoms or any viral infection. But right now, there is no evidence exists to support this postulate. So again, and again, you cannot diagnose any type of glomerulonephritis without tissue diagnosis. Kidney biopsy is the master. Of course, if it is not contraindicated. Pathogenesis, it is ANCA, and no need to put you in this dilemma. So I'll skip this slide. Pathology, again, it is not yours, but you have to have a small idea. It is renal biopsy specimen. It shows diffuse proliferative necrotizing glomerulonephritis with a crescent formation. Crescent formation, it is a very bad prognostic sign. Rapidly progressive, again, and the worst. RPGN, it is a horrible term. RPGN could be what's called anti-GBM antibody disease. GBM means glomerular basement membrane. It could be immune complex disease or post-immune disease. So it is not yours, but you have to have an idea. Manifestations almost the same. Pain of muscles, hematuria, systemic system symptoms like fever, malaise, myalgia, weight loss. Lab studies, again, we will go to do renal workup, but in special situations, we have to do some parameters like ANCA and anti-GBM antibody. Treatment, I have told you the common type of a treatment between all entities are corticosteroids, but sometimes we add cyclophosphamide. We do what's called plasma exchange. It is a technique to get rid of the toxins of the body from the plasma exchange or a plasma pheresis. Sometimes we go to renal transplant, but the prognosis, it depends on many factors. I have told you, the time the patient is coming, the smartness of his attending physician, and it's a matter of luck at the end. How he will go, how he will be stable, or will chronize and go to end-stage kidney failure. And I think I have finished this very hard topic and very hard collection of syndromes. And right now, even between nephrologists, it is still a controversial issue, and no one may agree with his colleague. But the 2 points, which are the key points, without kidney biopsy, we can't diagnose glomerulonephritis. On a clinical grounds, we can go to an impression, but we don't confirm our impression without kidney biopsy. And remember, steroids are a common factor in the treatments of most of those entities. And now I have finished. It is my last session in this semester, and I hope and wish all of you will be successful, and I hope progression to you in medicine, which is, again, a changeable and tough career. Thanks so much.